We'll start with some introductions now. Renee, would you mind introducing yourself again?
Not at all. Renee Bolio Banks, Indigenous College, Daganashimang, Indujaba, Magazine Indudame. My name is Renee Bolio Banks. My spirit name is Zibikwe, River Woman. I'm from the Leech Lake Nation, the Eagle Clan. I've been at NACC for a little over 5 years. I'm an elder in residence, and it's an honor to be able to do the blessing for you all today. Have a good meeting. Good.
Dr. Ravi.
Hello, my name is Kari Rabi. I'm a family practice and addiction medicine physician here at NACC, and I've been here for I can't even remember how long. It's been
13 years.
13 years. Thank you. So happy to be here and see all of you.
Rich and Nikki.
Hi, my name is Nikki Jardina. I am a public health nurse. I've been at NACC since 2017, and I do infectious disease nursing and some MAT nursing as well.
And I'm Lindsay King-Cooney. I'm the harm reduction coordinator and also facilitate this echo along with the rest of the team that just introduced themselves. Happy to be here. I'm gonna move on to some announcements. I'll share my screen. All right, so welcome to the Midwest Tribal Echo. We're the opioid use disorder education and treatment series. Today we're going to be talking about ME, CFS, and long COVID with Dr. Stephanie Grach. Welcome, Stephanie. A little bit about NACC, if you're not familiar. So we are the Native American Community Clinic. We were established in 2003 as an FQHC, and we're located in the heart of the urban Indigenous community on Franklin Avenue. And this is a list of all the wraparound services that we provide, and we are a full spectrum primary care clinic. This is a list of all the current open positions that we have at NACC. So feel free, there's the website at the bottom to go to that website and go to the job section and read more about those openings. Some session guidelines, please note protected health information. And if you could stay muted if you're not speaking. If you're able to turn on your camera, we would love to see your faces during the session. And then if you could let us know who you are in the chat, your name, title, organization, and email, that helps us to give you information after the session. And then some announcements on our upcoming ECHO sessions. Our next session will be September 18th, so in 2 weeks. We have neurobiology of substance use disorders. And then our next one will be in October, which is to be determined. This is a list of other echoes that cover similar topics that we do. And if you need, if you'd like more information on these, just let me know. We do offer continuing education credit for those who are eligible. We just have you complete the post-evaluation survey to receive the credit, which I will put that link in the chat and email out to you as well. And then finally, case presentations. If you do have a case presentation, we'd love to start including those into these sessions a little bit more. And my email address is at the bottom there. So if you have any ideas, feel free to let me know. I think that's all for me. I'm going to stop sharing and I'm going to hand it over to our speaker. Take it away, Stephanie.
Yeah. And so let me, it looks like, I think I'm going to show the right slide there, or right window, too many windows on the computer. Can you see slide all right?
Yep, looks good.
Perfect. All right. Well, I'm Stephanie Grach. I'm an assistant professor of medicine and attending at Mayo Clinic in the Division of General Internal Medicine. I specialize in long COVID, myalgic encephalomyelitis / chronic fatigue syndrome, fibromyalgia, postural orthostatic tachycardia syndrome, POTS, along with other infection-associated chronic conditions. So I'm excited to get to talk with everyone today. And let's move. Let's see. There we go. Now we got the keys working. All right. And so just a disclaimer that pretty much anything I mentioned today, just by the nature of these conditions, is going to be off-label that I mentioned. And so that's that. And just to start with a case to start things off. So have a patient, 46-year-old with mild COVID for a week, has a family history of autoimmune conditions, but nothing major personally or other family history wise. But 2 weeks after her COVID resolved, she started having new symptoms, debilitating fatigue, unrefreshing sleep, trouble with thinking, starts talking about like kind of fogginess feeling in her brain fog, lightheadedness, dizziness with position change, along with a lot of other symptoms. And so so this is a slide that's taken from a echo that we did on long COVID through also Stratus Health and the Minnesota Department of Health. It talks about identifying and managing long COVID as well. So one of the ways that I like to approach long COVID, so those kind of continued symptoms, usually lasting at least 3 months after COVID infection, tend to fall into 2 buckets for me. I'll tell people that one category, one of those buckets, is what I think about as like the familiar conditions in the medical field, the ones that we learn about, that we're taught about, that we can send to a specialist and they'll generally know what to do for them. So if COVID triggered rheumatoid arthritis or triggered psoriatic arthritis, then I know the rheumatologist will know what to do with them. If it triggered asthma, then the pulmonologist. And then the other bucket is kind of the less familiar conditions, really emerging topics in the medical field. And these are the areas of ME/CFS, myalgic encephalomyelitis, chronic fatigue syndrome, fibromyalgia, POTS, among others. And so one of the things that I really like to ask when I'm trying to figure out with my long COVID or other post-infectious patients or people presenting, especially with very profound, substantial changes from fatigue and disability, is how does activity affect you? And so she says, it's terrible. I used to run daily without any issues, but now when I do something as simple as grocery shopping, I feel like I pay for it for days afterwards. And what she's describing is a concept of post-exertional malaise, and we'll get to go into that a little bit more as part of my talk. This is the hallmark symptom of the condition that I'll be talking about today, which is myalgic encephalomyelitis / chronic fatigue syndrome. So learning objectives, identifying ME/CFS and post-exertional malaise, again, that hallmark symptom. Summarize potential causes and risk factors for ME/CFS, develop a framework for counseling on pacing as activity management, which is key for the management of ME/CFS. And it turns out a lot of other post-infectious kind of long COVID patients. Review non-pharmacologic management as well as pharmacologic options for ME/CFS. So what is ME/CFS? Per the WHO classification, ME/CFS is a neurologic condition affecting multiple systems, including but not limited to the immune system, metabolic system, cardiovascular system, among others. It is not the same, importantly, as feeling tired from being deconditioned. It's not due to psychiatric causes. And it often gets confused with the symptom of chronic fatigue because of the name, which is why I tend to say ME/CFS rather than just chronic fatigue syndrome, especially since patients usually don't find that chronic fatigue syndrome really captures the experience with the disease. There's different severity levels in ME/CFS, and by listening to your patient's story, you can generally get a pretty good idea of where they fall. About 25% fall into the mild category. They will often have a reduction in work or school hours, or they exchange essentially their personal lives for work. They pretty much just work or go to school, and then they say, I can't really do anything else afterwards, and I'm resting all weekend. And notably, this is already usually an average of 50% less function from their prior illness. So I'll ask, where were you compared to your baseline of 100% before things started? And even mild is 50% less of what they were able to do before. Moderate, a significant reduction in work and social activities. So people may be very part-time, few hours or a couple days a week, or starting to just not work at all, can manage a fraction with portioning out again and extended rest periods between. And then 25% are classified as severe or very severe, which equates to being housebound or bedbound respectively. And people who are very severe may be completely dependent on all cares. Why is it important to talk about ME/CFS? So before COVID, there was already an estimate of 2 to 3 million people in the US living with ME/CFS, and those numbers are increasing with long COVID. There's been estimates of, especially from the earlier strains, 50% or more of people essentially qualifying for the ME/CFS diagnosis in the context of long COVID. So that is, if we're thinking about how many people there are now with long COVID around the world, tens of millions, estimates of 15 million. Living now here in with ME/CFS, and that comes with higher economic impact. Talking about how it affects their function, and economic impact is thought to be $51 billion now annually, not including long COVID triggered ME/CFS. And as I mentioned, it's not usually addressed in medical training, or if it is addressed, it's very superficial. And so that makes it really difficult then for providers to know what to do with this condition when we haven't gotten any tools to work with it. Recognizing ME/CFS, hoping to support you in learning and understanding more about the condition so that, by identifying, eventually you'll be able to also manage and help these people with ME/CFS, because that can really change the trajectory. Here we have a figure from our publication that summarizes common presentations of ME/CFS, along with 2015 criteria that I'll list out. Essentially, you can see that a lot of different body systems can be involved. You'll see there's the primary criteria shortly that'll come up, but just wanting to point out that depending on the person, you can have so many different body systems that are involved in this. Again, we're really seeing that neurologic impact, the respiratory, musculoskeletal, urologic, really just goes to show the multi-system effects of the condition. But the specific diagnostic criteria are listed here. Because there's no specific diagnostic biomarker at this time, diagnosis is made on a clinical basis. And there have been several criteria that have been proposed, but the US mostly uses the IOM-NAM 2015 criteria, which stipulates having a significant reduction in function, which is accompanied by new profound fatigue of at least 6 months based on this criteria, not fully alleviated by rest. So most people, they will generally have some level of fatigue at all times. Post-exertional malaise, I'll come back to in a second, but unrefreshing sleep, so wake up, they never feel refreshed in the morning, and either cognitive changes, brain fog, and or orthostatic intolerance, feeling lightheaded, dizzy, or just really unwell when they are upright. And so post-exertional malaise, again, I have highlighted, this is really the key symptom. It is characterized as a crash or a flare of the symptoms that we just saw in the prior slide, generally occurring at least 12 to 48 hours after increased physical, emotional, or social activity that would have been tolerated prior to illness. So it really can be anything. It's not just physical activity, and there's often a delay. People will often say, oh, the next day, and then for days afterwards. And so this is another figure that we have from our paper on diagnosis and management of ME/CFS that has a representation of, again, all these different symptoms that people with ME/CFS may say. Very common for me to hear things about how my body feels like there's concrete in it, like it's poisoned, like I'm sinking, I can't move from my body, in addition to flu-like symptoms and the autonomic symptoms, so nervous system symptoms, changes in body temperature, intolerance, increased sensitivity to light, sound, smell, things like that, and cognitive changes as well. Again, important to differentiate that post-exertional malaise is not being more tired than usual after activity. It's not deconditioning, and studies have demonstrated that consistently, that it's a different process. It's different from that second day muscle soreness with working out. And again, it's not necessarily relieved by sleep. So thinking about the actual patient experience, because that's a lot of kind of heavy terms on the other one, things that I'll hear. I used to run marathons. Now getting groceries leaves me in bed for days. I try to push through, but I hit a wall and I just can't. Like my body is filled with poison and lead. I want to do things, but my body won't let me. And that's so key because a lot of people say, well, you're sure it's not depression? And in depression, people generally don't want to do things, right? But here, their body physically won't let them. And often I'll hear, I'm so excited to have a good day when it does happen that I try to do as much as I can, even though I know I'll pay for it. ME/CFS can affect people of any race, sex, ethnicity, social status, and so on, but it is considered primarily female predominant disease, so 80% thereabouts. I'll say it's more commonly identified in white, middle-aged, and well-educated patients. However, I think that's very much an issue of access, because studies, including in the Native American indigenous populations, actually suggest that there is a 2 to 3 times a more greater risk for ME/CFS, and this is true of other like the BIPOC populations in general. So commonly thought of as kind of the white disease, but that's not actually true. Onset tends to be around adolescence or middle age, especially with our post-infectious long COVID type cases. We see a lot of people around like the perimenopause time coming in. But it's important to know also that up to 90% of cases are estimated to still be undiagnosed. Usually diagnosis will come years after onset. The average is 5, but there are people where it's gone 10, 20, 40 before they finally got their diagnosis. Risk factors, there are genetic forms of the condition that are inherited through family members, and there's increasing evidence for concussion, major trauma to the body, as well as potentially emotional trauma, but really often tends to be the physical forms. But really the big one is infection. Again, COVID, mono, EBV used to kind of be the big one before COVID came on the scene. It's estimated that 70 to 80% of cases are post-infectious. And people who have other infection-associated chronic conditions, these other complex diseases that again, kind of, as I said, fall into this other bucket, especially things like fibromyalgia, POTS, IBS, mast cell disorders, hypermobile syndromes are very often coexisting, and we do often see overlapping either like immune deficiencies or autoimmune and neuroimmune disorders, because there is thought to be an autoimmune component to at least some of these cases. Physical exam wise, there's no specific exam finding. Probably the closest to being specific that I'm finding more now is this tenderness where the skull meets the spine, at least in a subgroup of patients. They may have tender lymph nodes. Abdomen might be uncomfortable to palpation. You'll often notice transient word processing or other cognitive difficulties, a lot of like issues with like word recall, or just seems like they're slowing down over the course of the visit that you're having, as well as progressive difficulties with fatigue, just looking more tired and like they can't keep up. Remember, so what's really important to note, especially for us in the healthcare field, is that just because the patient looks good on the day that they see you doesn't mean that they aren't sick. As I mentioned before, so symptoms can vary day to day. And I would say ME/CFS is most obvious when they're experiencing post-exertional malaise, but a lot of times patients have learned to rest and kind of minimize their exertion the days before our appointments so that they can tolerate going to the appointments. So they'll be on their good days when they see you, they may look normal. But oftentimes they're going to be paying for it after. So it's that reminder that invisible illness is not the same as absent illness. If you find some other things on the physical exam that can help with potentially some other coexisting conditions, diffuse tenderness suggests potential coexisting fibromyalgia, joint hypermobility, think about hypermobile spectrum disorder or even hypermobile EDS, orthostatic intolerance, red or purple legs with standing, overt tachycardia, the high heart rates, coexisting POTS is very common, if not just orthostatic intolerance in general. If you're seeing synovitis, major swelling, notable loss of sensation, Cushingoid features, etc., you shouldn't be seeing that from ME/CFS alone. So think about other things that may be playing a role. That's where the lab workup, so we have kind of a base lab workup that we do that looks at, of course, blood count and electrolytes, but also some hormones, autoimmune factors, just to make sure that there isn't another reason for symptoms that could be going on. Though certainly both can exist. So usually what I'll say if I have someone who may have a couple of things going on, but they're currently meeting the criteria for ME/CFS, is say like, hey, I want you to kind of follow this pacing activity management. We'll talk more about with ME/CFS. If we end up treating this other component and everything gets better, that's fantastic. But since I don't know for sure that this is going to go away, let's keep this in our mind for now about ME/CFS still, because you can have both. Your tests are normal is a really good statement to patients who are early in their diagnostic odyssey. But for the people who have been doing this for months and years, not really a great statement for them, because they're just trying to figure out, well, why do I feel this bad? So make sure you reassure, but don't dismiss. We know that standard tests don't show every condition. The basic blood work doesn't show multiple sclerosis, or, we have specialized tests for a lot of things now. And so we shouldn't expect it to necessarily be different with ME/CFS. Some other testing that I find helpful, as I mentioned, a lot of people with ME/CFS have orthostatic intolerance, so don't feel well if symptoms worsen with upright posture. The kind of formal test to look for POTS or orthostatic intolerance is a tilt table test. This isn't always accessible everywhere, and we know that. So one of the other things is on the other side of the screen here is the NACC lean test. It's an in-office version that you can do, where as long as if you have two people who can help with the pulse ox, so checking the heart rate, checking blood pressure about each minute, documenting what symptoms or physical exam findings you see, you can mimic in a lot of ways that tilt table test for much less expense. Some quick things on pathophysiology and ME/CFS. We're learning more about it now. So as I mentioned, genetic predisposition, there seem to be epigenetic drivers certainly playing a role as well. So we're learning more about that. It seems in a lot of cases that essentially an immune or infectious trigger will come in, anger the immune system. There's thoughts of like viral reactivation components, but essentially immune system gets angry. I'll tell them the nervous system gets angry with it. We'll have issues with immune system like chronic activation and impairment. It's not sending signals the way it's supposed to. Similarly, nervous system, neuroimmune dysregulation, neuroinflammation is demonstrated in these patient populations, resulting in dysautonomia, so issues with the nerve signaling. Again, mitochondrial dysfunction, issues with the gut. We kind of see secondary neuroendocrine disturbances as well. So a lot of complex things happening. There was a pretty cool update that came out in the last year that demonstrated how the cellular processes were being affected in ME/CFS, this WASF3 protein. And so they were actually able to demonstrate when they kind of changed that component in the cells, the mice that they were using showed post-exertion malaise, 50% reduction, and then they were actually able to treat it with an experimental therapy that helped the mitochondrial complex energy production again, and it reversed. So this is kind of an exciting development in the area. This is a part of a guide put together by the Myalgic Encephalomyelitis International Consensus Panel. It does a nice job of summarizing some studies that demonstrated physiologic differences between patients with ME/CFS and those without. Again, I don't expect you to remember all of this. It's just interesting to get to see, because we can see the same on some of our testing, changes in cardiac output, cerebral blood flow. So blood's not getting to the head the way it's supposed to. The VO2 consumption on testing, cardiopulmonary exercise testing, for example, we see that that's impaired. So the body's not using the oxygen energy the way it's supposed to, cytokines, things like that. So this is more, again, just demonstrating how many abnormalities we know there actually are, despite this historically being a medically unexplained syndrome. And this was actually all put together 10 years ago. So that's what we had then, and there's even more data now. So how do you explain all of this if interested? So example general explanation that I'll use, it's very complex, but essentially your body can't use energy the way it's supposed to. And when you try to use it, you pay for it because your body can't keep up. We think that this happens in many cases because the immune system and the nervous system aren't quite keeping in line after the infection, the trauma, whichever trigger, and it throws off their balance. And since all systems are interconnected, this makes everything else feel worse too. So that's kind of a general explanation that one might use with patients. For the orthostatic intolerance and to component brain fog explanation. So this is a pretty interesting one too. So I'll tell them it's normal to lose some blood flow to the brain when standing, but usually when the body will compensate pretty quickly. So most people don't feel lightheaded or fatigued, brain fog, etc. But whereas people without this condition lose about 7% when they stand and the body compensates, people with ME/CFS average a loss of 26 to 28% of blood flow to the brain with going upright, and their bodies don't regulate as quickly. So it's no wonder you might feel unwell with standing. And again, highlighting with the studies that looked into this, that remained true when accounting for deconditioning with control patients too. This is just a slide I like to share briefly because what was interesting in the study on ME/CFS from Columbia is that they showed that the immune signatures, the cytokines, the way the immune cells were signaling in the first 3 years of ME/CFS was actually different from those who'd had it for longer than 3 years. And of course, that was different from the controls. But what's really, I think that has important implications on ME/CFS and post-infectious conditions. And we see this in some of the outcomes too with our long COVID patients. Ones that we catch earlier may have a better chance of seeing improvements compared to people who are caught later. And so, or we may just need different therapies. So I think that's a really, it's interesting. And I think it's a good call to us to be vigilant and trying to identify these things earlier before the immune milieu shifts. Managing ME/CFS. So we'll talk about pacing and review some different options otherwise. So this chart again, post-exertional malaise, hallmark symptom. If you want to manage ME/CFS effectively, then you have to manage post-exertional malaise, because if you don't, if patients keep flaring with their post-exertional malaise, we see that they get worse and worse over time. So the first goal of reducing post-exertional malaise, the first goal of ME/CFS management is to reduce post-exertional malaise. We do that with pacing. So in the simplest language, pacing is being active when able and resting when tired, or when patients feel their warning signs. Not everyone gets warning signs, so there's actually some tracking apps now that can be helpful, but a lot of patients will notice that, for example, the heart rates will go higher, or they experience more twitching or fatigue, and that is their sign to stop, rest, and pace. Preferably if they can do so with their feet up, especially if they have orthostatic intolerance. In doing so, they can often prevent or at least reduce the severity of that post-exertional malaise episode the next day. As I mentioned, so exertion is not the same as exercise. Exertion, it's important to incorporate that into the counseling. That incorporates physical, cognitive, social, anything that your body is spending energy on. And so that's important to keep in mind. And then pacing also acknowledges that each day is individualized. So what someone can do on one day may not be the same on another. Ways that I think about this. So there's different metaphors: energy envelope, smartphone battery, spoon theory, hashtag spoonies on social media. The way that I like to talk about it is an energy budget. So if you have $5 to spend for the day and you're trying to spend $6, you don't magically get more money to work with, even though I wish that's how it worked more often. Instead, you go into debt, and then your body has to work on building back up that budget again so that you can spend again. Similarly, though, in the same way that people who budget their money well may then over time have more to spend. Similarly, people who pace well, who budget their energy, may ultimately get more over time as well. And so this is a guide by NACC, one of the community and advocacy groups. They have both national chapters as well as a Minnesota, different state chapters on pacing. And as mentioned, there's an app for that now, which is pretty cool. We see a lot of our patients with ME/CFS and long COVID really benefiting from these trackers. So again, the goal of pacing is to reduce post-exertional malaise, not necessarily to increase activity over time. However, as mentioned, when they budget well, at least a portion of patients may find themselves actually being able to tolerate more activity over time. And that kind of makes sense as far as like the less that you are aggravating the body, the more you're letting it come more to its balance, the more likely that it's going to sustain better over time. Scheduled graded exercise. So saying specifically, okay, each week you are going to add like 5 minutes of walking. We've seen that does not work for these patients. It can worsen post-exertional malaise and disease severity. And so we will see people potentially get worse from that. That's why pacing is very much the activity management as soon as I think that ME/CFS is at play. Some other helpful management, anything that helps with reducing that nervous system activity in general. The sympathetic part of the system, that fight or flight, is the one that's going to be more activated in these conditions. We have seen in studies that there's actually damage or other issues with signaling from the vagus nerve. So because of that, the sympathetic part of the nervous system usually is overshooting. So things like meditation, massage, deep breathing, biofeedback can be very helpful in helping calm the sympathetic system. Reducing stimuli, exertion for especially severe patients, light, sound, all of that can count towards exertion and energy use because of the way the body's processing. So if they, especially post-exertional malaise, but that or if they're severe or really even mild can benefit too, potentially considering specialized sunglasses, darkening rooms, using headphones, limiting long conversations and avoiding crowds, different things, smells, if those aggravate too, to reduce that sensory overload on the body, on the nervous system. Heat and cold therapy for temperature changes. Thermal dysregulation is very common and often especially heat intolerance. So having things like fans or cooling jackets can be very helpful for this population. Encourage fluids, electrolytes, compression. These are recommendations from the POTS group, but as mentioned, a lot of people with ME/CFS may also have orthostatic intolerance, and they can find this helpful as well. Usually 2 to 3 liters of fluids, electrolytes. I'll say add 1 in the morning, 1 in the afternoon is helpful. Compression, usually abdominal and thigh compression, because we're getting closer to the heart, to the head, is going to be more effective than socks alone, even better if they're together. Monitoring hours of upright activity. So especially if there's orthostatic intolerance, how much they're upright is potentially more draining, more gravity effect on them. So laying down is generally better tolerated over the time of the day. And usually you'll find that anaerobic resistance type exercises, weights, body, are going to be better tolerated than things like cardio. That makes sense as far as the mitochondrial dysfunction. The mitochondria don't have as much room to work with for that. So we see people tolerate, if they're really interested, if they're able to incorporate exercise and they want to, that's usually how I will counsel them. And similarly, again, with the orthostatic intolerance, recumbent, so lying down, is going to be much better tolerated than upright forms of physical activity or exercise. Medications. So there are potentially effective medications in ME/CFS. There's kind of 2 realms that so far have been studied. One, medications with neuroimmune, so calming that neuroinflammation side, that can be helpful. Examples of these that have been studied are low-dose naltrexone, low-dose aripiprazole or Abilify. So at those lower doses, we see that that inflammation around the glia, microglia, and astrocytes actually improve, and along with that, symptoms. And then the other side is, we mentioned that the nervous system is more active, that sympathetic system. And so medications used to calm that can be helpful as well. Starting with low-dose naltrexone. So it's a medication that's also used off-label in fibromyalgia, as well as autoimmune conditions. And currently there are active studies in ME/CFS as well as long COVID for this. Most commonly will compound to about the dose of 4.5 milligrams daily. Usually capsules will be somewhere 1.5 to 4.5. People with major medication sensitivities can start even lower. I have 0.5 here, but you can actually go even a lot lower than that with liquid formulations. So if you have someone who's been very reactive, I will usually say start the liquid form at 0.1 milligrams and just increase every few days or few weeks, depending on tolerance there, until you build up to 4.5 or whichever is your most tolerated dose. Again, everyone is different. Some people do well with less, some people do well with more. Pyridostigmine. So this has been studied at Brigham and Women's in particular. We see that pyridostigmine can actually help improve that peak VO2. One of the metrics or one of the values that we saw was abnormal in ME/CFS by increasing cardiac output, improving the right ventricular filling pressures. And so similarly, we may see that people who take pyridostigmine in ME/CFS have better so fatigue can improve, exercise or activity tolerance, I should say, can improve. And pyridostigmine is also a medication that we use in POTS. And so that can be great for that POTS overlap as well, or orthostatic intolerance. And finally, low-dose aripiprazole, which is more popularized by the Stanford group at doses, and their study was 0.2 to 2 milligrams. So I usually will do 0.5, so they can cut the pill in fourths, which can be, sometimes that's very tiny. You can also compound for lower doses if needed. And a good number of patients, almost 74% reported improved fatigue, brain fog, post-exertional malaise symptoms. I actually find low-dose aripiprazole to be particularly helpful for sensory sensitivity. So when they have really bad sensitivities to light and sound and other things, see some good effects with that. And so this is just a summary of those medications. Low-dose naltrexone, again, up to usually 4.5 milligrams dosed at night, usually unless vivid dreams occur. And so most helpful for fatigue, brain fog, post-exertional malaise, and pain, especially if there's that fibromyalgia or autoimmune overlap, is a great option. Low-dose aripiprazole, that 0.5 to 2 milligrams, helpful for similar symptoms, but especially those sensory sensitivities, at least in my experience, can be helpful for anxiety, depression overlap, but that's not needed to prescribe either, of course. Pyridostigmine, 15 milligrams up to 60 milligrams 3 times during the day is most helpful, again, for fatigue, post-exertional malaise, orthostatic intolerance. It's also really good if someone has constipation with it because it helps, as you may know, with moving the bowels along. So more common side effect is loose stools. But if they have constipation, it's a great option for them, great for POTS overlap. And if they have had that cardiopulmonary exercise testing, seeing that VO2 can be another sign. I'm selective on cardiopulmonary exercise testing just because people, after they do that, they can often have pretty bad crashes afterwards. But it is one of the mechanisms. So a 2-day CPET is one of the ways to demonstrate ME/CFS for disability. So it may come up, but if you do that, be sure to counsel patients about that potential for post-exertional malaise and worsening. Lots of supplements that patients will often try, especially since they're not usually able to get prescriptions to try other things from their medical providers, at least historically, that's changing. And we're seeing a lot of really cool, more advanced therapies come out now that have a positive signal with them, ranging from like IVIG, immunoabsorption, Ampligen has been used historically and helpful. There's more trials for things like rapamycin, some of the antivirals, some other immunomodulators. So cool things coming. Pitfalls with the studies in the past, especially, it's hard to tell if ME/CFS was diagnosed correctly because it was commonly misdiagnosed in the past, especially with that chronic fatigue issue. And so also noting that the current criteria 2015 may differ from some other ones. We're probably seeing also different etiologies for ME/CFS. We're trying to figure out if it was triggered by COVID, if it was genetic based, other reasons for it. even though it looks like the same end state, is it going to respond differently to different treatments? So I tell patients, this is a poorly defined and phenotyped disease, unfortunately. So when we see positive studies not always being replicated, we should really ask, is that true, or are there misdiagnoses or subtypes that we need to be looking into to really clarify that more? So with our research, we need to have more insight on driving pathophysiologies versus secondary findings and subtyping to safely determine treatment responders. So a negative study shouldn't say necessarily that that medication can't work. If there is a group, even a small group within that seems to be responding, then pursuing that more intently. So example approaches to management based off of what we talked about. If they seem to have some of those signs of ME/CFS, but they don't have that post-exertional malaise, evaluate for other causes, monitor them, see them back in 6 months, see if something else has come up. If they do progress onto ME/CFS with post-exertional malaise, that symptom being present, pacing as soon as possible to prevent worsening, prevent those post-exertional malaise flares as best possible, and considering medications. Examples being if they have pain and paresthesia, you can think of pacing for ME/CFS along with fibromyalgia neuromodulator therapies. So we'll do that. Confirmed ME/CFS and orthostatic intolerance, pacing plus POTS therapies can still help, even if they don't always meet the full criteria for the other diagnoses. We find that similar approaches, similar therapies can still be helpful. If you have access to Ask Mayo Expert treatment algorithms, we have clinical algorithm on how to approach ME/CFS, what to do based on management for different symptom, how to address different complications. We also have this paper out, as I mentioned, diagnosis and management of myalgic encephalomyelitis / chronic fatigue syndrome, published last October, that goes into a lot of what was really the main highlights that you need, especially from the primary care generalist view on approaching ME/CFS. When the patient is still worsening, having minimal response to pacing, LDN, pyridostigmine, aripiprazole, and so on, think about those other coexisting conditions, POTS, fibromyalgia, mast cell. There's also a lot of potential structural contributors now that we're learning about in the research related to the spine vascular compression. So a very interesting area, and hopefully we'll be able to understand more about those in the near future. But again, also consider other conditions, especially neurologic, rheumatologic, or endocrinologic diagnoses. So just a quick example to wrap up of how you might approach them. Communicating with the patient, you think they have ME/CFS, again, your test is normal, tests are normal, good to someone who's early in the diagnostic odyssey potentially, but not so helpful to those who aren't. Reassure, do not dismiss. And you could say something like, based on the symptoms that you're describing, I do think that there's a condition that might match. Is that okay? Is it okay if I share the criteria with you and we see if it might fit your case? So often I'll pull up, one is the CDC IOM criteria, just put that into Google, I'll pull this up, have them read it, or now sometimes I'll give the article and let them look over that. And if they say, yep, that sounds just like me, then you can start talking with them more. And oftentimes patients are just really excited that someone has seen them and recognized them. Especially in these cases, I let patients know that the understanding and management of ME/CFS is very different from where it was even a decade ago. So, and I think of medicine as being like an iceberg where we have some strong knowledge of things that are just above the surface of the water, but there's a lot more lying underneath. And I think that ME/CFS is really just at the surface there. So patients will understand that you won't be able to know everything about ME/CFS. You won't know all the answers. And trust me that I say, though, that they'll just be happy to have a provider who recognizes what they're going through. So next steps, planning regular follow-ups, recognizing the condition is complex. I need to do multiple visits to make sure I get your symptoms and look over everything, but also shorter visits are often appreciated because of energy use. If feasible, offer video or electronic visits to reduce travel, and give resources for the patient to read for the next visit so that you don't have to do as much of the information overload in that first visit with you. Some example resources for patients. So the paper can work as one, but there's also our webpage, CDC page, ME Action, which is a community group, as well as an advocacy group, as well as the Bateman Horn Center. ME Action resources. Top one is the national group, and the bottom is ME Action Minnesota, and how they can help. The Bateman Horn Center website, I love the guides that they have. They have the MECFS Crash Survival Guide for post-exertional malaise, but also different sheets and cards that can help them with organizing their medical information, or if it's hard for them to even speak because of the post-exertional malaise, can communicate better with those cards. Some additional resources for provider. There's a lot of consensus clinician coalition guides that are out there, international and US MECFS based group, as well as the articles listed. And so thank you again for having me, letting me speak to you today. I know there's right now there's a big initiative by ME Action across the nation to improve knowledge around MECFS and their Teach ME, Treat ME initiative. So more information at their website. And if you're interested in looking at the article that I brought up, as well as doing the CME related to it, there's QR code and links here. And so that is that. Thank you again for having me.
Thank you, Stephanie.
Thank you.
There's a couple of comments and questions. Do you want to stop sharing your screen and we can get to Isaac has had a question for a few minutes. Isaac, did you want to ask your question?
Yeah, you can hear me okay?
Mm-hmm.
Great. Yeah, so I'm Isaac. I do pain management up at Health Partners and see a number of patients and work a lot in this field as well. First, thanks for a great talk. I really appreciate you talking about this and bringing it up. And it's not often that I learn some new stuff around this, but I actually did learn some things. So I just, again, really appreciate your talk. I have actually a lot of questions and comments, and maybe I'll just ask a couple and then maybe I'll email you some other ones.
Perfect, yeah.
But one of the questions I have is, especially about the pacing, is the question I have is about starting. So, you know, I have a lady who says, you know, I lift a fork out of the sink and I'm done for the day. And so it's hard to really sort of say, how do you pace for something like that? So for some of the patients that are maybe more severe or have that narrative about how severe their illness is too, how do you talk about pacing when they feel like they can't do anything without a flare?
That's an excellent question. And oftentimes when it comes to the more severe, especially the very severe, pacing is not really the option that we'd like it to be. You know, it's very practical for mild and moderate. As you get more severe, less so. That's where you can think about at least like sensory sensitivities. There's ways to reduce sensory input as part of that exertion, but that's really when I'm looking more towards medications. And even when I might explore some of those emerging areas in the structural for especially very severe. POTS is one of the most common overlapping conditions that I find really decreases function in our MECFS patients. So POTS evaluation and therapies tend to be another like promising area to try and start with.
Great. And then I just make one comment. I think when I go through kind of similar information and put all together sort of the immune and neurologic interaction and then show the overlapping conditions, that is really, really important for the patients. It sort of takes, you know, I have 100 things wrong to, oh, I got a nervous system that's not working right, or an immune system that's not working right. And that's a lot easier for them to kind of digest. And it actually starts reducing some of the anxiety about their illness too, which is another big part of this as well. So I just wanted to sort of piggyback and cheerlead the importance of sort of trying to get a diagnosis and present some of this information, because it really makes a huge difference for people. And then I'll send you the rest of my stuff through email. Thanks a lot.
Awesome. Looking forward to it.
Thanks, Isaac. There's a couple of comments in the chat. Stephanie Wren put in the chat, increased sensory sensitivity being a part of that post-exertion malaise makes so much sense. Definitely consistent with my lived experience too. Going to have to look into this more for sure. And then Linnea asked a question. It seems that some people may recover from this disease, but others may have it for the rest of their lives. Are there any clues to know if a patient will recover?
Yeah, I think this is something that we're learning about more because of long COVID. This is one of the first times that we've really been able to take a look at early post-infectious infection-associated chronic conditions, including ME/CFS, to be able to see that trajectory. So, for example, in our long COVID group, or kind of these early phases, there may be people in like the first year or two where they'll start having more spontaneous improvements, more spontaneous recovery, and that ends up kind of leading the way. We are hoping that with supporting people better in the early stage, that it may allow for more of that. But really, our data shows, I should say data in general, so all the places that really work with these conditions, is that even with earlier intervention, the true recovery rate has remained at 5 to 10%, at least in the adult population. And so people seem to be doing a lot better than what they could have been because we're not letting them progress, and we're helping to support their symptoms better. But true recovery, it's still not quite entirely clear. There have been spontaneous cases, still trying to figure out why that happens. We've had cases that when they meet another immune kind of response, so had actually COVID, I don't recommend getting COVID again or something to try and knock out long COVID, but we've had some people where there's an immune reset with like that and taking like monoclonal antibodies, for example, which unfortunately keep going like on and off, but primarily off the market based on variant. I'll say that adolescents do generally have a better chance of having a recovery compared to adults. Some of those figures go up to like half, 60% of recovery. Part of that may be that they also will have more of an orthostatic intolerance, a POTS component, and as that gets better managed, the ME/CFS may also be more likely to improve. But yeah, there's kind of that adolescents are more likely to improve compared to adults, but otherwise still figuring out those exact recovery likelihood features, if you will.
Well, thank you so much. I think we're at time. Thank you, Stephanie, for a great talk. Would it be okay if I shared your slides with the group today?
Yeah. Great. Absolutely. And I'd also be really open to hearing if anything gets passed along, especially as it relates to the Native American Indigenous populations, if there's kind of stories around this condition, how that might be talked about or represented. I think that'd be really cool information for us to know, because I know we're very interested on the clinician side of understanding also the cultural overlaps. So would love to hear anything if you end up knowing about it.
Great. Well, thank you again. Thanks everyone for joining us today. Our next session will be on the 18th of September, and it will be the neurobiology of substance use disorders. So I hope you can join us again. Thank you. Have a wonderful day.
Thank you.